Good morning, guys. I have discussion for you this morning. We are discussing uh, sedatives for older adults and the effects it has on them. So here we go for today's A. So please join me for today's presentation. Here we go. Antipsychotics and other sedative drugs, including low-dose ones, are being prescribed more often to older adults because clinicians are using them off-label to manage insomnia and difficult behavioral uh, symptoms of dementia, often as a quicker substitute for non-drug care or for sedatives that have fallen out of favor. This rise is happening despite strong evidence of serious harms in seniors. Why prescribing is rising, the deeper forces behind the trend, escalating behavior crises in dementia care. As dementia progresses, many older adults experience agitation, nightmare or nighttime wandering, shouting, hallucinations, or aggression. These episodes can be frightening and dangerous for the individual and exhausting for caregivers. In overstretched home settings, assisted living facilities, and nursing homes, staff often reach for medications that promise rapid calming, even when the evidence for benefit is weak. A shift away from benzodiazepines but towards other sedatives. Benzodiazepines like lorazepam have long been discouraged in older adults because of their high risk of falls, confusion, and dependence. As prescribers reduce their use, many have substituted safer seeming alternatives, such as quetiapine or trazodone, but these substitutes are still act as sedatives and carry their own risks, especially in frail seniors. Primary care pressure and limited specialist access. Most antipsychotic prescriptions for seniors come from primary care clinicians, not from psychiatrics or geriatric specialists. With short appointment times, limited behavioral health support, and few non-drug resources, medication becomes the most practical, if impacted or impact tool. Off-label off-label prescribing for sleep and agitation. Low doses of antipsychotics are frequently used to help with insomnia or nighttime agitation, even though research shows minimal benefit for these symptoms in older adults. The convenience of a pill often outweighs the uncertainty of non-drug approaches. Systematic understaffing in long-term care facilities with fewer staff or less dementia care training are more likely to rely on sedating medications to maintain safety and manage disruptive behaviors. This is a structural issue, not a not an individual failing. The safety problem. What the evidence shows. Increased risk of death. Antipsychotics carry an FDA black box warning for older adults with dementia because they raise the risk of death from cardiovascular events and infections, falls, fractures, and hospitalizations. Sedatives impair balance, slow reaction time, and worsen confusion dramatically, increasing fall risk. Stroke and cardiovascular event. Antipsychotics can disrupt blood pressure, heart rhythm, and vascular stability, raising the risk of stroke or heart complications. Cognitive decline. Some sedating medications may worsen memory, accelerate confusion, or contribute to delirium. Long-term use is common, even when intended as short-term. Studies show that once older adults start sedatives like benzodiazepines, many remain on them for months or years, despite guidelines recommending short-term use only. Why this matters for families and caregivers. The rise in sedative prescribing isn't just a clinical trend. It's a reflection of the real pressure families face. Sleepless nights, safety fears, burnout, and limited support. When a loved one is pacing at 3 a.m. or lashing out in fear, the promise of a medication that helps them rest can feel like the only option. but the risks are real, and the long-term consequences can be profound. What families and caregivers can do now: ask why the drug was chosen and what the goal is. Every sedative should have a clear purpose, e.g., preventing harm during a crisis, and a time limit plan. Request a medication review. A geriatrician, pharmacist, or dementia care specialist can help evaluate whether a medication is necessary or if safer alternatives exist. Explore non-drug strategies first. Environmental adjustments, structured routines, sleep hygiene, sensory interventions, and caregiver coaching often reduce agitation without medication. If medication is unavoidable, choose the least risky option and insist on a deprescribing plan from the start. Bottom line, the increase in sedative prescribing reflects a collision of clinical urgency, caregiver distress, limited resources, and systematic gaps in dementia care. But these medications carry documented, sometimes life-threatening risk, and their use should always be cautious, temporary, and paired with non-drug supports, whenever possible. A conversation script. Here. Hold on, guys. I'll be right with you. Now, here's the second part of 8 for y'all. 3-sentence overview, grounding the issue in current data. 5.7 million older adults on benzodiazepines, 20 to 30% using them longer than recommended. Why this happens. Bulleted explanations covering quick relief, prescribing patterns, long long initial fills, driving long-term use, off-label prescribing of antipsychotics, withdrawal barriers, and limited clinical follow-up time. Major risks. Each risk falls, fractures, cognitive decline, stroke dependence, mortality. Drug interactions includes a brief data point, e.g. 50% higher fall risks, 67% higher hip fracture, FDA black box warning on all antipsychotics. What families should ask? 5 ready to use phrases caregivers can read about out aloud, or bring on paper. Safer alternative and next steps. Non-drug strategies, CBT, sleep hygiene, structured activity, calming routines, plus safer pharmacological options, SSRIs, busprenone, melatonin, agonists, RNX, and medication reviews. Researchers and clinicians. 6 primary sources, including the Samash Dear Colleague letter, just a second, guys. Be right with you. Criteria 2023 AGS Alternative List, July 2025, and key published studies. Part 2 Clinician Conversation Script. Talking to the doctor about sedatives, medications, is a separate standalone page with 5 labeled steps a caregiver can read aloud, an appointment, or paste into a patient portal message. Okay. Basically, these are just suggested notes that somebody could use. Opening line sets a respectful, collaborative tone. Names the specific medication and risks. Request for review. Asks about necessity, safer alternatives, and drug options. Request a timeline, limited plan, and taper. Ask for 4 to 8 weeks timeline with gradual dose reduction. Request for a follow-up review data. Ask to put a 4 to 6 week reassessment on the calendar. It closes with a practical tip box reminding caregivers to bring a full medication list, noted side effects and specific concerns to the appointment. Nothing has been set or published. The document is yours to review, edit, and print. Okay, guys, that's A for you. I will be back on in a bit with B, and we will get going for shows today. I'll be back on for B shortly. See everybody shortly for B.